Good afternoon, everyone. So we arrive at the final session of Annual Conclave 2026. This session asks us to look at systems, at policies, at technologies, but all while placing people at its core, at its center. Every health system builder knows one thing: systems are sustained by communities. And community resilience is not a supplement to health systems resilience, it's its deepest foundation. This session brings together practitioners, civil society leaders, and community health advocates who work at that frontier. We begin this session with a spotlight presentation by Dr. Shweta Singh. Dr. Shweta is the technical head for research and public health at Access Health International. Dr. Shweta's professional journey is marked by her roles at both the state and national levels in human resources for health, comprehensive primary health care, maternal and child health, and health policy. Over to you, Shweta.
It's a- So today, I'll be speaking about one of the Access Health International own initiative, which is around health literacy intervention on non-communicable diseases in Chhattisgarh. So in this session, when I'll be using the term NCD, it will be largely in the context of these health conditions, that is hypertension, diabetes mellitus, oral, breast, and cervical cancer. So we all know how alarming NCD is in India. So 1 in every 4 of us are at the risk of dying from NCD. Now, in response to these challenges and burden, Ministry of India has undertaken certain initiatives to be named as NP-NCD program. Then in 2016 came the population-based screening, and a huge push came to NCD agenda under Ayushman Bharat CPHC component. But in contrast to this, if you look at the data in state, particularly in Chhattisgarh, around 53% of the Delhi in the state is contributed to NCD. Looking at NFHS data, when it comes to screening, for example, hypertension, it is around 52, which is very suboptimal. And when it comes to cancer, it is around 2% or even below for certain cancers. So we all know there is a clear gap between what policy intent and what is actually happening on the ground. Now, while health promotion, awareness, generation was always a core component of most of the national health programs and initiatives that take place, and we also realize and evidence strongly suggests that patients with NCD require continuous support and monitoring throughout their life. Now, why is this important? To improve their overall quality, to add healthy life years, and to reduce their secondary complications. What we all know, in contrary to this, the health facility contact session that take place between patients and healthcare providers is very limited. When I use the term limited, it is largely in the context of providing continuous counseling, patient education, which and generating awareness so that they can undertake essential lifestyle changes, which is important to manage NCDs effectively at their own end. So addressing these problems at our end, we designed a project with the primary objective to co-design and implement a health literacy for non-communicable diseases in 2 blocks of Raipur and Garhyaban district in Chhattisgarh. Now, apart from this primary objective, there were a few secondary objectives as well. The first one was community empowerment. When I say community empowerment, it was more largely in the terms of generating their better knowledge and practices in terms of NCD and their associated risk factor. Apart from this, we also build a focus on building the skill and capacities of community health worker because we know they have the essential foundational skill, and to undertake any such interventions in the future, they need to be upgraded, and which is also essential for sustainability and scalability of any intervention in the community health settings. So if you look at the underlying philosophy of this intervention is knowledge enhancement, behavior change, and overall health system strengthening. Now, to design a very informed intervention, we started with the baseline. In baseline, our aim was to understand what are their current knowledge, attitude, and practices in terms of NCD, what is their health-seeking behavior, what are their screening practices and their preference when it comes to seeking treatment and care. We also try to understand in terms of health literacy, what is the capacity of the community to assess, avail, understand, and use of health information. The aim was very simple: to establish a baseline metrics, to identify the knowledge gaps and misconceptions, and to understand what are the priorities of communities so that a very well-informed intervention can be designed. Now, I'll just display here the major insights that is coming from this baseline assessment is that While communities have a decent understanding when it comes to hypertension and diabetes, but the understanding is critically low and alarmingly low, I would say, here when it comes to cancer. Health literacy, they find it difficult to assess the credibility and relevance of health advices when it comes to multiple sources, so leading to confusion. And they also find it difficult to make a decision on their own whether they should go for a secondary medical consultation or not. Similarly, in community health system, community health workers, which is also called as Mitanin in state, have a decent understanding of NCD. They are trained and they have a long lasting trust from the community given their years of experience working very closely to them. In terms of health system has effective delivery mechanism in terms of trained HR available, functional infrastructure. However, there are a few reports of stock out of NCD drugs. Now we also had a look at the policy, what policy and program guidelines says. So largely, health literacy exists in the form of information, education, and communication, largely through pamphlets, poster, sometimes slogan writing, very clearly defined and demarcated under various vertical health programs. So actually, they don't take into consideration what is the current community or patient education status, what are they demanding of, and what are the current disease prevalence. So all these important aspects which need to be a part of health literacy or any health promotion awareness is being neglected. Now, the geographical coverage of the intervention currently covers Tilda in Raipur block and Manpur in Garyaband block. So we basically wanted to have a good mix of urban-rural area, and Manpur, particularly in Garyaband, has a tribal pockets. So because largely the Chhattisgarh state is a tribal dominant state, so we wanted to have a mix of the demographics into it. So currently the intervention is being operational across 21 villages, which is covering around over 5,000 households. Now, here in this part, I'll be speaking more in details about how these community sessions are using participatory approaches being implemented on the ground. So these sessions are basically open to all community members in the age group, irrespective of the age group, class, and gender. They are open to participate in this discussion. So basically, these community sessions take place by a trained facilitator along with a supervisor, which essentially take place the documentation. Mitanis, that is the ASHA workers in the state, also participate and be a member, very active member of these meetings. So they also participate in mobilizing participants to attend these sessions. So currently, the scenario is that we organize one session every month, and there are structured 11 structured modules which take place. So till date, as I speak of, we have covered around 319 sessions, which had more than 5,000, 5,500 participants be a part of those sessions. So the approach we have adopted here is a very community-centered approach. In a monthly session, we ensure that each hamlet is being covered in the villages so that villagers find it very convenient to move outside their house and the session is being organized. So traveling is not a problem. Community integration. When I say the term community integration, here the participant is not only community health workers, but we have also made sure that panchayat elected representatives are a part of these community sessions wherever and whenever possible, so that looking at them present in those community sessions gives an assurance and a bit acceptability to the community that if their leaders are coming and sitting in those sessions, some important conversation is going around. Also, we have used various participatory tools such as social mapping, spider diagrams, stress walk, case studies, visual aids, so that people open up and discuss their problems and how they perceive whole NCD and the risk factors associated. Also, these sessions happen regularly on a monthly basis so that continuous and consistency reinforcement of these health messages and concepts can be done over a period of time. So the mantra here is very simple. Empowerment through participation, not just information dissemination. So these are various topics related to non-communicable diseases, ranging from health promotion, tobacco, stress, climate change, um, diabetes, cervical cancers, and their associated activities and the focus area. So the total intervention duration is around 4 years, and we are somewhere mid of this journey. And after, in these 2 years, a lot many insights are coming from the community in these 319 and 20 sessions. So we have compiled a small video out of these learnings, and I'd like to just put it on a display now. Voice is not coming.
In semi-urban communities of Chhattisgarh. In the heart of this state, diseases like hypertension and diabetes have become a silent but major burden. To tackle this, we adopted the community session using participatory approach to empower our communities. Our mission focused on two diverse landscapes, the semi-urban Tilda block in Raipur and the tribal, rural terrain of Mainpur in Gariaband, turning awareness into collective action. This program was not just about giving information, but an initiative to empower villagers to take leadership of their own health. Through these community sessions, we held in-depth discussions on health, risk factors, and major NCDs, such as tobacco alcohol consumption, stress, BP, diabetes, and cancer. In these sessions, community participation and deep learning experiences emerged. Come, let us see how the understanding of health changed in these villages and which challenges we can all fight together. In the first 4 sessions, the program shifted community perceptions from a narrow view of health to a holistic understanding that integrates physical, mental, and social well-being. By addressing the cultural normalization of substance use, dietary shifts toward processed foods, and the heavy physical toll of stress, the sessions successfully linked daily lifestyle choices to the direct prevention of chronic diseases. The next 3 sessions were focused on high blood pressure, BP, diabetes, and cancer. In the BP session, from the spider diagram, it was revealed that people understand the connection between BP and stroke, paralysis, but they feel that too much stress is the main reason. The person who remains in too much stress, because of stress also BP becomes high. Along with this, there was also awareness about the dangers of leaving medicines in the middle. In the diabetes session, people knew that this disease happens due to blood sugar increasing. They knew symptoms like tiredness, frequent urination, and wounds not healing. They also considered alcohol and tobacco as risk factors for diabetes. In the cervical and breast cancer sessions, we broke social hesitation and silence through the stories of Meena and Radha. In women, hesitation towards not talking about problems related to physical organs was clearly seen. Because of shame shyness, women did not tell anyone about their problems and did not go to the health center either. Lack of awareness, treatment being expensive, and the indifference of men are the main reasons for delay in the diagnosis among women. In the oral cancer session, Vijay's story put forward the terrible consequences of tobacco consumption. Villagers came to know that persistent ulcers in the mouth or difficulty in opening the mouth can be dangerous symptoms, and people above 30 years of age should do regular screening. The essence of these community sessions is that the rural community of Chhattisgarh is ready to learn and change. A significant gap exists between health awareness and behavioral change. While participants demonstrated a high level of awareness regarding the risks of tobacco and alcohol, this knowledge rarely translated into behaviors. This suggests that health literacy interventions must address deep-seated cultural norms rather than just providing medical facts. Financial strain, stemming from unemployment, debt, and lack of stable housing, emerged as the most prominent stressor for families, particularly for women. This stress is further compounded by invisible caregiving roles and domestic instability caused by spouses' addictions. Gender dynamics create a silence around reproductive cancers. Although women were the most active participants in health sessions, female-specific NCDs like breast and cervical cancer remain heavily stigmatized and are often considered taboo to discuss. The use of participatory approaches was instrumental in fostering community trust and collective problem-solving. These methods moved beyond traditional education by making intangible concepts like stress visible and providing a safe way to discuss sensitive health issues. Now let's hear from the participants about their experience in the community sessions.
अपने काम में ज्यादा ध्यान देते था, अपन शरीर के ध्यान नहीं दीवान छोटे मोटे तकलीफ रही थी वो छुपा रखते था और गैस संचालित वाला सर मन आई से मन हमला बताई से छोटे मोटे तकलीफ का दवा नहीं रखना है और तंबाकू गुड़ाखू खान तमुन छाला के तब तुरंत दिखाना है कैंसर के रूप ले लेते ऐसे करके हमारा सारा जानकारी दी से कि सर दर्द है चक्कर आना हाथ पैर में दर्द तो डॉक्टर मन सलाह लेने से डॉक्टर जगह जा स्वास्थ्य विभाग में बैठा कोई से तो एक जानकारी दी से कि सर दर्द होगी डॉक्टर आ रही शुगर भी हो सकते शुगर से किडनी खराब हो सकते
और लीवर में भी हो सकते हैं प्रॉब्लम, आंख में भी हो सकते हैं, आंख में होते मतलब शुगर खावा की नहीं है पता चली तो डॉक्टर मन से सलाह लेना जरूरी है, इलाज करना जरूरी है और समय समय बीपी के जांच कराना है। अगर बीपी कम जाता है वो मुझे पता चले तो पता नहीं चली तो लगभग शिकायत भी जा सकते हैं।
शारीरिक गतिविधि के टॉपिक में मैं यही बताना चाहती हूँ कि जैसे कि हम लोग मीटिंग अटेंड करने के बाद हम लोग को पता चला कि शारीरिक गतिविधि हमारे दिनचर्या के लिए बहुत ज्यादा अनिवार्य है। इससे हमारे शरीर को बहुत सारी ऊर्जा मिलती है और एनर्जी फुर्तीला अनुभव होता है। मीटिंग अटेंड करने के बाद ये सारी जानकारी हमें प्राप्त हुई।
Thank you, and gratitude to you for staying connected in this journey of health.
Thank you. I think we are in the middle of the journey, and in the next phase, we are planning to also approach, apart from the community sessions, we will be moving about the HWC and utilize that space also for undertaking similar interventions along with the state government in Chhattisgarh. Thank you.
Thank you for this one insightful presentation, Shweta, and helping us deep dive into the wonderful and rooted work that you and your team are doing in Chhattisgarh. So we now move on to the last panel for this year's conclave. I will now call upon the panelists to come join us on the stage. Please join me in welcoming Dr. Ramakrishna Prasad, who's joining us virtually today. In fact, Dr. Prasad is a family medicine physician and the convener of the Comprehensive Primary Healthcare Alliance, CPHC Alliance, one of India's civil society bodies working to scale community centered primary care. His current areas of focus are how to reduce the policy intent to performance gap in CPHC and how can comprehensive primary healthcare systems be scaled. A warm welcome to you, sir.
Thank you.
Next, I would like to welcome Dr. Kapil Sharma as Joint Secretary of the Indigenous Development Organization, or IDO. He works to expand the health access in tribal and underserved communities in Telangana and Chhattisgarh. A homeopathic physician by training, he has spent his career ensuring that the communities most invisible to the health system become most seen. Welcome, Dr. Sharma. Next up is Mr. V.R. Raman, the National Convener for the Public Health Resource Network. He was one of the members of the Metanin program, the Community Health Worker Initiative that Shweta just spoke about, that became a national model for grassroots health mobilization. He has spent decades building the state civil society partnerships that make health systems accountable to the people they serve. Please join me in welcoming Mr. V.R. Raman. Also on this panel, we welcome Mr. Ashish Manawar. He's the Program Manager for Innovation at the Resilience Collaborative, a platform dedicated to frontline innovation and health systems readiness. As part of the innovation focus at the George Institute, Ashish helped to set up the India Health Accelerator and Fellowship Program during the pandemic, aimed at supporting frontline innovation among health professionals and entrepreneurs. His work lies at the intersection of community action and institutional support. Pleased to have you with us today, Ashish. And now I hand over to Dr. Reddy to please join us on the stage to moderate this discussion. And I would also like to thank the George Institute for being the session co-hosts and for partnering with the collaborative on multiple occasions. Thank you.
Yeah, thanks, Tuti, and thanks all the colleagues and the dais, and also Prasad online. Welcome for this last session. I do see that still audience is fully alert and they are actually keenly listening to this last session. Just to set the context for the discussion, I also would like to give the background of how the journey around this thematic area of what can be done at people as a theme. I mean, basically, we always say people-centered healthcare, but we only talk of 6 building blocks of health systems. We don't talk much about the people. So as a part of these learning sessions, the conceptual understanding evolved and a lot of peer-to-peer learning sessions have happened. And some of those ideas, as Shweta has presented, are being translated into action. So this is an illustration of how these learning sessions are actually translating some of the conceptual understandings around a particular theme or the sub-theme into actionable insights with a demonstrable transformation, whether it's strengthening of health systems or building resilience in the community or within the health system. So our focus has been, as an organization also, we are testing variety of interventions, like all of you are testing variety of interventions in the context of community. I mean, while we talk of strengthening health systems and making them secure and making them more resilient, so we have been, I think all of us have been asking what can be done at a people level. People level also, whether it is done by themselves, people themselves, like now families can take care of themselves with so much technology advances. So second is their own self groups helping each other, peer-to-peer support groups helping each other, and then learning from some of these crises, and then learning from what one family did and one family did not do. And then there are community-based organizations which are rooted in the community. They have the trust of the community, like I do is there. And with that trust in the community, you are trying to bridge what they are unable to get from the public health system or even the private healthcare system. Okay. And there are similar civil society organizations, I mean, I think which Raman represents, in terms of understanding what is the local governance and its responsibility and its accountability to the health of the people at the local level. And also what is the participation of the people in the governance function. In fact, as a part of the GLC learnings, the framework, I mean, the picture that is depicted outside also, the health system framework, if you notice carefully, there is what are called triangles of governance. Because we always equate governance with the governments, but it is a triangle. Government does not work in isolation. So there are people, public sector, private sector as a whole system, or there is a people, the providers and the payer as a healthcare system. And each of these angles of the triangle, they have roles, rights, responsibilities, and accountabilities. It's not just the government is accountable. It is the private sector is accountable. Even people are accountable for their own health. It is not that people are not accountable. They have rights, but they are also accountable for their own health. So these are some of the underpinnings of trying to test what interventions can actually empower people to build resilience within the community. I'm not talking of health systems resilience, but build resilience within the communities. Some of the 4 or 5 elements that came out, again, during the learning sessions, just like the general literacy, the health literacy empowers people. Just like illiterate versus literate, the health literate and the health illiterate, there is a difference. The very awareness of health makes them empowered. If they are aware, I mean, today their awareness comes from the Google doctor, and they're able to question me why I did not advise this test, right? So that is empowerment. Otherwise, they would have accepted whatever I say is Veda vacuum, right? They don't question me why I advise this test and why I advise this treatment. So that's why, so health literacy was given. In fact, the project that we undertook on our own in Chhattisgarh was on that context. And demonstrate as a part of this ongoing study that it really is empowering people and improving their health and improving their health seeking behavior. That is also equally important, the health seeking behavior, health living behavior, and overall health. So these are some of the examples that I think this session we would have a good discussion from the speakers with rich experience and representing different aspects of this community intervention. For example, if I start with Mr. Prasad, Dr. Prasad, in terms of what he is attempting to do. From a policy design perspective, from National Ayushman Bharat design perspective, and India's policy attention has been on building primary health care. And recently, with the transformation, building comprehensive primary health care, not just the primary health care focused only on mother and child care or vaccinations, but looking at it in a more comprehensive fashion, including the community level aspects of it, not just at the clinic level aspect of it. So we'd love to hear from you, Prasad, in terms of your own approach and your own assessment of what the policy program is attempting to do, and what are the still challenges, some of the surmountable challenges and the gaps that are there, and what could be the potential solutions to overcome. I mean, we have created, I think, close to 160,000 now health and wellness centers, with the idea of transforming them into comprehensive primary health care. So what is the ground level situation? I mean, since you are grounded and you experience the ground level situation, because we have to face the truth. I mean, we face the truth. We know where we are. Once we know where we are, then we know where to go. Okay. And also, solutions can come collectively. I mean, solutions can come from the community itself, from the frontline health workers, from the researchers. I mean, most of the solutions actually come from the ground. Research only capture those solutions. And of course, research claim that these are our solutions. So over to you, Prasad. I think just share your own experience and viewpoints on this approach to the comprehensive primary health care.
Thank you so much, Dr. Reddy. I have a few slides which I will just project. And all right. Is it? Are you able to see my slides now?
Your screen, we are able to see.
Can you see it now?
Yeah.
Okay. So, 1 second. Just have to present on this device. Yeah. So it is. Okay, thank you so much. Thank you for the wonderful and actually very grounded introduction. I am a practicing family medicine physician, and I have spent the last several years looking at comprehensive health, CPHC, comprehensive primary health care, both as a practitioner at the ground level, seeing patients every day, mostly in rural Rajasthan, also in Punjab, in Karnataka, and in Bihar. These have been the states I have worked the most closely in. But also as someone who can looking at the system as a whole and how interactions happen. So my central thesis today is one of the problems that I see when I look at the concept of resilience in the context of CPHC, or comprehensive primary health care, is this is actually something which needs an ecosystem approach. Even if you take, for example, and say we know that primary healthcare is local. In fact, it is hyper local. The way one village or one neighborhood operates can be quite different from the way some other village or neighborhood operates. And this capacity or resilience actually is co-created between multiple different influences. One part of which is community agency, which you and Shweta have spoken about. The second part of this is actually whether the local units, primary care units or primary healthcare units, are able to recognize, respond to, adapt to, and remain accountable to evolving community needs. So, for many communities, there is a persistent gap between primary care service delivery and community realities. This results in low trust, weak continuity, and fragile resilience. And also, I want to point out that many times what happens is there are many different actors, stakeholders who are all trying to solve this problem. But given the complex adaptive system challenge that it represents, or the wicked problem that it represents, we often solve only that which we understand. But one needs to take a ecology, ecosystem approach to this. Um, I want to spend a minute or so. This is a paper we recently wrote from Rajasthan. Many of you may know the work of basic healthcare services in Rajasthan. So, this was a patient, this was a teenager, this was an adolescent girl who the primary care team I suspected and identified a very fairly rare kind of tumor, which is called a schwannoma. The point is not whether the tumor was rare or not, but I want to show you the different types of barriers which actually influence resilience even in a case like this. So this young girl who was about 15 years old, she developed some symptoms, but it took almost a year for her before she even went to her local primary care clinic. And the main reasons for this are there is fear. And in some of the rural tribal areas, distance is a significant barrier. And then in some of these communities, the father or the male member in the family often migrates. So we saw it in the presentation, the video Dr. Shweta showed. So till the decision maker who has access to finance or money does not come in, there is often delay in health seeking behavior. Then what happens is when someone goes to the primary health center, sometimes we confuse primary care with just something which is basic. But actually, primary care is quite complex. So it requires relationship building, it requires clinical acumen, it requires sustaining a relationship, building that trust, multiple rounds of counseling, and counseling, not just information giving, as has been pointed out very nicely, but a form of empathy, demonstration of support, and navigational support. Even if you tell a patient, please go to the big hospital 100 kilometers away, go to see a surgeon there, it's impossible for most people to just access services. It requires multiple trips. Even when thoughtful physicians, doctors write referral letters to other doctors, many times these are it's the system is not very responsive. So I won't belabor the point, but this is exactly how care is experienced by most people, most communities in India. um, we are currently completing a landscaping study, and Dr. Reddy, this is actually based, the foundation of this is work that you were recently involved in, the value based care strategy document, of which you are one of the co-authors. We took that as a starting point. And then from there, we are landscaping and having deliberative dialogues with three large communities. One is the community of innovators and providers. And India actually has a number of innovators, but most of them working at, in very local areas without actually scale intent or being connected in a scalable kind of manner. The second is the community of government administrators and government people who manage government health systems, and thirdly, payers and funders. So the main finding that we have come upon is that community resilience is actually shaped by this interplay, which I just spoke about. And then there are three main problems, which I'll call the structural misalignment or triangle failure. The first problem is that providers, even extremely competent and committed providers, are actually unable to demonstrate outcomes. They are able to demonstrate activity, but not outcomes. This makes it hard for payers and including patients who pay. The biggest payer in the country is out of pocket payment, which is made by families. Even families, unfortunately, today cannot demand and establish outcome accountability. And to scale comprehensive primary health care, one needs to have denominators. And these denominators are often missing. Like, who, for example, a health and wellness center which has been set up, even if on paper you say that it covers a population of, let us say, 3,000 to 5,000 people, you actually do not know exactly which villages are covered, and is this the only place they go, or is the district hospital closer than the health and wellness center from many of the households. um, and lastly, funders or investors cannot sustain prevention and health promotion because there is an attribution gap. You do not know what you're investing in and what the return of investment in that local area is going to be, even if the evidence shows that there is ROI and social ROI which a certain approach has. Lastly, I'll emphasize that fragmented care pathways without there is lack of clear ownership of who ensures continuity and coordination of care. What I will do is, I know time is short, so I will go to the main take-home points that I want the audience to consider. The main take-home points is that unless we look at comprehensive primary health care and health systems as learning health systems, it's actually difficult to build resilience and adaptation. So the main points I want to leave all of you with are: number one, community resilience is not only an inherent property of communities, but it is something that emerges, evolves, and often emerges due to that dynamic between the system and the community. Second, when the biggest issue is actually this weak enabling ecology, often there is absolutely no inbuilt continuous learning and quality improvement at the local institution level. So many times, for example, if you go to a health and wellness center, even if there are it's a very high burden, say the local community has a lot of patients with diabetes, but the register itself has only 10 entries. It's not something the local unit actually is able to process, adapt, engage with the community on, and the community also. And this is because there are data gaps, data not so much in collection, but in sense making and communication, etc. And the big issue that was something that many of us are working on, which is called the CPHC Design Lab, is looking to work on is how can we improve the quality of primary care services and its engagement with communities, but also address simultaneously issues of misaligned financing, weak accountability for defined populations, fragmented data flows, and unclear ownership of care coordination. So I'll leave you with these thoughts, and I look forward to adding more as the discussion proceeds. Thank you.
Yeah, thanks, Prasad. I think it's a beautiful systems thinking in terms of approaching this comprehensive primary health care. While you outlined some of the actors in the ecosystem, if I have to reflect, I mean, in terms of it is not only the people and the health system, but also the other non-health systems with relevance on health systems. So that means there has to be an interface between the three elements of that. The second point, which I'm very particular, is always the health systems try to respond to the seeking behavior, the demand of the patients. But the needs, health needs, if we look at, the health seeking is only when they have suffering. But health needs are when they are not suffering. So the system has to look into both the sought health needs and unsought health needs. It's not just one of them. These were some of my comments on the ecosystem approach, and will be maybe by the next annual conclave, your lab, our CPHC lab, should bring out a lot more insights into the outcome of this approach, a systems approach to the primary care problem, not purely as a design principle coming from the top, right? Design principle coming from the top and expecting that the community is going to just take it. So that's the current approach. So given this, I think this also brings into the opening comments I made in terms of the interplay between the various actors in the governance spectrum. So that brings to me the panelist Rajan, since his work has been on the local governance, the role of people in the local governance, because we are a democracy and we elect our governments and we are responsible for our governments. Our elected representatives are sitting in the local governance, the ward members and sarpanch and other people. So given all these things, I mean, the current state of local governance, I mean, we have different states of local governance in different states. I mean, the advanced empowered local governance in state of Kerala may not be the same thing in other states. Since you have been deeply engaged in this aspect of the community level health, happy to listen to your ideation on these aspects of it.
I'm Raman, not Rajan. Yeah.
Oh, sorry. I was just mentioning my brain cells are coming down, my memory of remembering the names is coming down.
Last sessions.
Yeah.
Oh, so I started my journey towards health systems as a resident of Kerala, my own Gram Panchayat and all that. And that journey, while the Methanian program which was mentioned and the Swasth Panchayat, I was, starting those programs in Chhattisgarh way back in 2002. And one of the initiative was Swasth Panchayat Yojana at that time. So before that, let me just, since it's a very brief time that we have, one, I'm chairing currently a advisory committee of a Kerala's Gram Panchayat on health, and they have come up with a universal healthcare policy. I'm talking about a Gram Panchayat. And they have the NCD related issues so they have conducted a panchayat level out-of-pocket expenditure study and then have a population survey and have listed priorities and have a short-term plan and a long-term plan and even having a preventive, process. So for that, they have got experts across. Whosoever they knew, they called me and I had a lot of network. So that network is working on. So that is one level. So if I put that into an incremental, what you call roadmap towards that, because Kerala at times, although I come from there, at times I feel that it's not part of this country. Because whatever the literacy campaign was the first thing that I was out from Kerala, and replicate what we had done was almost impossible given the social situations and various realities of the broad. We call it a country, but it is much more than a country. Many of our states are, sometimes our districts are countries. So in Orissa, when I was working after that, the resilience issue that I'm trying to bring in, after the super cyclone in Orissa, I was part of a campaign called the Social Reconstruction Campaign. And we started a lot of initiative with the communities, then realized one thing that without, the panchayats were very weak at that point in time, because 93 was the time when the amendment came and panchayats were recognized as local governments. And before that, they were since one agency, IRDP and various programs. So they were seen as one agency, but this local government, or in the resilience language, you ask this question that is important, that whether it is people-led or it is peer-led, what is that people-centered health systems? So the panchayats for me are the frontline government.
Right.
From that health system language I'm talking about. So this frontline governments, they are actually facing a lot of these issues. And our system, because it is top down, from 93 onwards, we started to speak about bottom-up planning, community planning and all that. But it is essentially, led by this top down. So we have not factored in these governments in our structure at all. So even when NGOs and the civil society organization, when we go to a district, the importance that we give to a collector's office is never given to a panchayat. Even a block development office is seen as quite prominent in terms of power, privilege, and all that. But this people's government, when we go, they are not seen with that prominence, and that is where in Orissa this particular lesson came in, as if they have clearly they have role, they know that they have a role, but what role is not told to them, the specific kind of a thing. So whenever we had the specific roles told to them, these areas. So otherwise, they are only into that visible hardware kind of a thing. They may build some buildings, roads, those kinds of visible things, but the soft areas of life, which is so how to build up a panchayat level health system was a question that I was asking Uttar Pradesh later after this Orissa one. Then during the disaster, this was seen that the panchayat leadership actually they are making it possible within the gram panchayats, and there is some continuum. Not just some action happened and then there is no one after this NGO left. So the panchayats were taking it over, and then they were. And currently, Orissa has become one of the most resilient in terms of disasters. It is coming out of this contribution that the panchayats have made. And even you would have seen that during COVID in Orissa, there was a special order by the government giving some executive powers to the Gram Panchayat Pradhans. It has both sides. Some of them are very useful. Some problematic issues were also there. But it is important that this came. Then in Uttar Pradesh, there was a triangulation that was done. Panchayats, community members, and different government departments together. We were trying to build a district health systems there. Multi-sectoral approach to health was the project. And I happen to be the chief functionary of that project. And then this particular issue, panchayat health plannings were started based on panchayat data. So when panchayat started to see the data, then their approach to health totally changed. So then, we realized that when we say panchayat, even panchayat is heterogeneous. Because within that, you have in UP, panchayats are smaller, and in Chhattisgarh also panchayats are smaller, wherein, you have hamlet habitations and villages. Villages, the main village, have all the kind of privileges, wherein the surrounding villages, there are caste systems informing it, influencing it, and there are many other factors that is influencing. So unless and until you see the panchayat within its heterogeneous identity, it's not going to work. That was another important thing. So in Chhattisgarh, when we designed this Swasth Panchayat Yojana, it was developed as an index. It is called Health and Human Development Index, not Human Resource, Health and Human Development Index. It was made for 68,318 habitations of Chhattisgarh, all habitations. And they came up on 27 indicators. They came up with the local data. What is the situation from health, various aspects of health, including water, sanitation, and all that. So this is called the Swasth Panchayat Yojana. And that started, again, what Shweta said is very important in terms of NCDs and all that. Awareness is there, action is not there. Why is that this particular problem? So action starts from some feeling of ownership and authority. If you are just a participant without having, you are not considered or regarded as someone who is leading, that leadership role, if it is not accorded, the problem is that we don't start to act on them. So when this leadership role, because this is Panchayat's health. So there was one document that we had written, all of us in the people science movement at that point in time. The document was 94, placing health into Panchayat's agenda. This document is quite important. Then it went into block level and district level, then reaching health to poor by the Lal Bahadur Shastri Academy for training the IAS officers, upcoming IAS officers. This document was developed. So all these had this idea that how the local level heterogeneity is accepted, the power imbalances are accepted, and the leadership, whichever power sector they are representing, segment they are representing, they are able to see the larger picture. How the panchayat is, which, maybe one para or hamlet, whatever you call it, access is not there. They are struggling the most. Whenever rain is there, they are facing more challenges. So when the panchayat is mapped and then intra-panchayat comparison is happening, inter-panchayat comparison is happening, then they know within my panchayat what are the problem, comparing to other panchayats what are the problem. So access to data is one of the, currently panchayats are collecting a lot of data, but they own a very few set of data. So the moment we are able to make them owners of their own data, because currently that is another important thing that in Chhattisgarh we were trying to develop with NHSRC's collaboration. We were trying to develop something called not the HMIS, where in the health management information system, we were trying to make it
Health information.
even further, health worker assistance system. Because this data, who wants it, who needs it, and who wants it, and who acts on it. All these are actually the local persons need it. The moment you have a panchayat level health information comes in, then there is a debate about it. This is lesser, this is what in Perinjanam Gram Panchayat, they are the advanced level in Kerala. So they were able to do that family level survey. They put up a report. They got interns from including the National Law University in Bangalore and all that, to look at how things are happening in their panchayats and then to make it into a policy statement and all. So there are advanced levels of that sort. In Chhattisgarh, the Swachh Panchayat Yojana, from 27 indicators, now they have reached to something like 20 indicators are developed, discussed, and put up on the panchayat meetings, and they try to endorse. And here is the important twist: social determinants are important. Your understanding of health situation, which is the kind of important determinant that is leading to this current situation. If you don't have control on that determinant, that determinant is controlled by someone else, then the local actors cannot do much. So how to make that specific determinant, also how to build the local actions for them, how to kind of design it in a way that the panchayats can think about. So if I in that Trivandrum experiment of comprehensive primary health care, uh, uh, it was very, very important when the panchayats were able to, pick up the Cuba model of family medicine, and then the panchayats were able to set up clinics and all that. So it was not coming out of this is some priority that is coming from the national health policy priority, but they were saying this is our health priority. So this level of action, if we are able to, make. Last week I was having a discussion with Sarguja's, district panchayat members, block panchayat members, and panchayat members together, panchayat sarpanch together. And in that process, they were able to think a lot of innovative kind of actions that they could have done, provided the problem is that 15th Finance Commission has earmarked a lot of funds. If you see that in the larger picture, we see that a lot of money is going and it is not spent. But the actual reality is that money is not reaching there. The allocation happens at the end of the financial year. Probably even now, today, it is 24th, 25th today. Some panchayats would have received the first installment of 25-26 now. And how would they spend it? So this kind of issues, the finances and the gender issues and the social determinants and the broader social sectors within. So how we can make a system which is actually building on that. I won't call them local body, I would call them local government, and we need to recognize and respect them from that perspective, and they will start to deliver, and they are delivering at different stages. Like reservation was happening in early days. It was a lot of humorous comments were made on them, and all those things that their actual power is exercised by someone else and all that. But over years, that particular situation has changed. In the last Chhattisgarh discussion, the men were so silent, and the women leaders, the district panchayat members and all, were very clearly putting up what needs to be done, what is happening, what is not happening, how we are going to lead and all that. So it is changing, although the desired level of change is far away. That's a different issue. So this gender issue, the social clusters issue, caste issue, all these needs to be understood. And then if we are making a panchayat health systems, that's what I would talk about. And then build on it block, district and state. This federalism, we have to recognize this 5 pillars, not just the national and state thing. We need to depart from that particular situation, and the resilience, we will see how it is coming in. Yeah, thank you.
Thanks, Raman. I think very, very educative journey that you illustrated. I mean, what actually already at an advanced stage in the Kerala state, and attempt to reach that state in other states. I think there is a hope. That means if one state could do that, there is a hope that other states can do that easily. And also there may be, again, in terms of its scalability across the country, in terms of its policy attention, both at the central level and the state level, and recognizing the responsibility that devolution is not on paper, it has to be actually felt by the ground level people when the money has to come to the panchayats. I'm from a village, so sarpanchas are committing suicide because they have not paid the money which was supposed to be due to them. Yeah, these are, I think, the ground level realities which you beautifully brought out, and also you illustrated how an effective local governance system, involved participatory governance system, can be highly effective. I mean, they can monitor the health of their population, the 5,000 or 1,000 hamlet or 5,000 people, and they understand which disease they have to prioritize. In fact, I mean, this is the element which Kapil might be bringing up now. I would like to ask Kapil. I visited the place where he is working. Very impressed. The transformation that a simple small organization like IDO could bring there in a population which is unreachable. So that is Kapil, I think would love to listen, because the tribal population, I mean, just like you have certain gender sensitivities, tribal population or different sensitivities will be there. Tribal population has a unique culture and tradition, and also their willingness not to trust outsiders. I mean, initially, right? Until so, as an organization, I think that was one of the, again, effective method of, whether it is IDO or whether it is government or whether it is another CSO, how to build that trust in the people and be accepted by them as one of them. So maybe that journey will be more interesting, actually.
Thank you, Krishna Reddy sir, for inviting us to this place, and a warm good afternoon or good evening to all the members here. Had a great opportunity to listen to so much over these 2 days, and understand different perspectives from different people or members in the various fields of healthcare. So yeah, I have a PPT actually where I can quickly take you through the journey of organization, how we built a cadre of tribal youth who are now taking charge of their health issues, and they are addressing their health issues at the front line through that empowerment that we have done together with the support of organizations like AQH and Tata Trust and other our partners. So, is there?
Yeah.
like Dr. Reddy sir has asked just now that how would you do it and how did you build that trust where the people will not trust you easily. So like rightly he said, so let us for a moment, though it is difficult to imagine sitting here in INSA in Delhi, to imagine, let us for a moment imagine a place where there is no access to safe drinking water, there is no access to electricity, there is no access at all to connectivity, there are no healthcare providers. Of course, there are healthcare providers from the community, but there are no healthcare providers of the modern medicine that we talk about. There is no Anganwadi, there are no designated Asha workers. There are people suffering due to malaria, malnutrition, pregnant women suffering with severe anemia, and there is no formal schooling and access to education. So let us imagine all these things. And again, imagine you are being displaced from your own home due to various reasons, and you migrate from a border in Chhattisgarh and you are started residing in the remote areas of Telangana. So this was the situation of the community that we started working with in 2017. So in Telangana, they call the community Gutikoya. So our special focus, our primary focus started with Gutikoya community, though now I do works for rural and tribal community as in whole. So these communities, so through a paper article, our team came to know. So Dr. Narendra, who started this work, senior from a medical college, he came to know that there are communities that are suffering with so much and they have so many challenges. And so we were happily practicing medicine in Hyderabad. So we wanted to do something else and we started the journey. And once we visited, we were surprised to see the challenges that were like in the. So we talk about rising Telangana, golden Telangana. So of course there are very good things happening there, but still, being a doctor, observing a pregnant woman suffering with having 2 grams of hemoglobin at 8th month, does not have single antenatal checkup. So these are some things that we observed initially, and we decided to work there in this area. And like I said, the community had to displace. So this is a Muria Gond community that displaced due to Salva Judum and other factors from Chhattisgarh. And in Telangana, in our district, Kottagudem, nearly 20,000 population stays in 134 villages. And on top of it, Niti Aayog also had labeled our district as one of the aspirational districts. Just to bring to your attention that the challenges faced in community, that is traditional practices, lack of connectivity, a child with pneumonia does not have proper what do you call health facility to go to, and they rely on traditional methods due to various century-old practices, relying on traditional these things, and home deliveries more than 80-85% when we started our journey. So what we thought is, once we started being with them and observing them after saying few lives, so getting there or winning the trust was not easy for us. After saving few lives, then they started believing us कि हाँ ये हमारा आदिवासी doctor है. Then they started gradually opening up. So that was also not enough. So we started staying with them in one of the remote tribal habitation called Krantinagar, where the community has built a small hut for us to stay with them. So we used to observe their overall activity, what are the things that they do in their days to day activity, what is the water source, what are the other issues. And then we understood that it is a comprehensive issue where education was lacking. There is no source for drinking water. In summer, they have to walk miles to get one pot of water and all that. And also, we parallelly understood what are the traditions. So, what I do, we believe that, see, empowering them also means that we have to respect and keep their cultural practices intact. instead of just putting some alien ideas into the community. So we believe that, so we empower them by understanding their cultural practices, and we work in alignment with the practice. Like, for example, if a child has fever and they want to go for a traditional healing, this thing, so we have a community health worker who also ensures that the person goes to that traditional healer called Vadde, and also parallelly uses our medicines or our intervention, whatever is needed, and tracks the patient. So things go out of hand, then it is immediately referred to the higher center. So to empower them, we have to be with them, understand their challenges, and do a regular hand holding, which is most important. Like we understand that at policy level, government designed so many good things, but at implementation level, when it comes to implementation, most things don't fall in place because of lack of handholding and regular follow-up. So at IDO, we practice this where we engage them at a regular basis so that they are empowered, and we listen to their again challenges from the field and try to understand, try to adapt our approach accordingly. So you can see we have also designed a small medical kit in a remote area where there is no electricity, no access, no network. A tribal youth, a male or female, can address the challenge at front line and give that assurance to a patient or a person suffering that we are here to address that challenge. And also they do hand holding referral. So that is again important because tribals does not like to, or due to various reasons, they are afraid of hospital. Language barrier is one issue. Finances are the issue. So the health worker being along with them in that referral adds a great value. So we encourage this, that health worker at least does that admission on a timely basis, tracks the patient and all that. Another important component is that in their, so to win their trust and to get it going, we should adapt according to their cultural practices. So most of the areas where we generally fail, so I'll give you one example, Dr. Reddy, that I have been to a tribal residential school in our district. So I observed closely that school for few years now. Over the period, I observed that why children are dropping out of the school, why they are not going. So we have a education initiative where we construct small huts called bed school in the remote area. We give them basic formal education, and after a period of 3-4 years, the child is ready and parents are okay. Then we put the child into the mainstream residential schools. Children are dropping out. We observed what happened. So again, like I said, it should be culturally appropriate. The school does not have any person who can understand their language. Simple issue. Children are dropping out. Again, if you see, there is nothing that reflects their culture. Only during some annual day, there is some fancy dress competition that happens. Otherwise, they have all that modern education going on in this so-called tribal residential schools. I don't know with what motto they have been established and over the period what motto has changed now. So this is a small example where you can see the child wants to, it is not that they are poor health seekers. It is not that they don't want to get education. It is just that it has to be addressed in their way, in not our conventional way. So we designed a program called Nukkad Natak, where the trained health workers or tribal youth, so the community generally loves to have this songs and dance. It is in their nature. They like that. So we designed the health awareness program in such a way that it is expressed in the form of song, home-based newborn care. So what is pneumonia? How a parent can easily clinically identify just by seeing what signs they should look for. So such interventions have created remarkable impact. It is an ongoing, and also if you see the pictures, we go according to that time in the evenings. It is not that you can go whenever you want. So whenever they are free, we have to plan. So grassroots initiatives, grassroots organizations like succeeded because we have adapted their culture, their practices, reaching different areas where there is no access. A small study for all of us to just reflect how these resilient health workers have, through their own hands, have brought down the infant mortality and maternal deaths and improved the institutional deliveries. If you can see, just see the institutional deliveries. So though we started working in 2017, and gradually we learned from different what do you call partners over the period that the data should be tracked. So we started tracking from 2021, where close to 77% deliveries are home deliveries in this 33 households, 33 habitations, sorry, and close to 5,000 population, 5,000 population. And it gradually dropped down, you can see, to 39% or 40%. And the whole institution deliveries gradually increased from 23% to 60%. So that there are things that we have to reflect here is, see, the trust in the government institutions may have slightly improved in the community through our intervention and government intervention. But also there was a very crucial role of this community youth, health worker, who understands their language, the patient's language, who understands their culture, and who is there to do the handholding. That is how we can bring change. Another good thing that I would bring here to the notice of all the members, that all our services are free of cost: health, education, community initiatives. But we don't want the community to become lazy. We wanted them to have ownership of it. And maybe through this education initiative, our plan is to hand over the reins of the organization to the next generation of the community. So with that perspective, once we started constructing the charitable hospital, which we have in the Kottagudem district of Telangana, you'll be surprised to know one person from each household on a roster basis, regular basis, came forward for construction of the hospital. And this is the outcome that you can see. And it is with being the representative of the community, I am very proud to say that for more than 15,000 people have contributed their physical time called Shramadhan, what we call, to construct this beautiful facility in the heart of the district. And it is the Telangana's only NGO charitable hospital with single specialty. So we have a gynec specialty here. And they celebrated that event when we had this inaugural. And at IDO, we practice that annually. We celebrate few events, encouraging community to keep their culture intact. And it is also opportunity for us to have a good meeting with them. And like I said, our another initiative, education, where we want to, so preventive healthcare is cheaper and curative healthcare is very expensive. So we believe that. And if you want to have this preventive healthcare, education is one of the resource. So we started building on that, and we have some 14 villages in remote areas where there is no education, and we have this bridge school concept. So I think it is a multifactorial or what do you call, multiple things should add up to empower the community. And these are few things that IDO has been doing in last 7-8 years of our journey. So we recently had a good study with the help of AQH, Access Health International, Affordable Quality Health, under the Tata Trust funded project. So just would like to bring to your notice about few current indicators of 20. This is a recent report. You can see still we have infant mortality rate of 52%. Institutional deliveries nearly 40% we have to achieve. And kacha houses and no toilet facility more than 90%. No electricity at all in nearly 58% villages. And you can see dependence on these water streams and dug wells, that is more than 70%. So no formal schooling, again 66%. Preference on traditional healers, more than 50%. So no ration cards and bank accounts. And you can also see villages with ASHA. Only 28% of villages now have any health worker or ASHA worker. So these are all the factors where we are trying to empower the community. So we hope that these empowered youth who have so much resilience and faced so much since their childhood, they have seen their houses being burned down. They have seen so much of problems in losing their home and coming to a place where we call them homeless in the homeland, basically. Still, they are so resilient and so empowered, so motivated to work for their people. And this is our idea, that our motto, that we should empower them and leave it to them so that they can take it forward. And on the indicators that we have seen, I'm sure maybe in next, maybe after 4 or 5 years now, we'll be in a far better position. Yeah, thank you.
Yeah. Thanks, Kapil, for that moving story. While you were narrating the story, I was reflecting as a researcher, what are the lessons that can be learned from what you are doing and how they can be scaled up. Right? I mean, some of the elements are already adopted in terms of the community health volunteers, their role, whether it is in Thailand or in India, most of the Southeast Asia and South Asia, because that is coming through again powerfully through your story, that how people drawn from the community connects the community with the health system. So I think that's the one message that is coming out very clearly. The second message that is coming out very clearly is in terms of a health system that is responding to peoples in all their dimensions, not only the health dimension, but also their cultural dimension, traditional dimension, socioeconomic dimension. So that is a desirable health system, what we call a responsive health system. Ideally, a health system is supposed to be responsive to the people's needs. The only concern I have is in terms of its scalability. I mean, so that's where I think we can take some lessons from other countries. We are working in Egypt, and they do have a policy, and they do have a budget actually for partnering with community-based organizations, where the government is unable to engage the community for whatever reasons, their own bureaucracy or whatever it is. They create a budget item for community-based organizations to extend that last mile services. So that's because there is a policy scalability. Because we have to see how what you are doing in your own capacity, how it can be scaled. It's not only the tribal population, it applies to urban population. Their cultural context is different, their traditions are different. If ASHA worker goes to urban household, she will be shooed away. Whereas the village, they will welcome her. The difference is there. So you need a different approach in the urban context. The same thing. In urban context, the community is the working place. It is not the living place. So you can say, I mean, we try to do that with the RTC employees across the depots. We selected 2 volunteers from each depot. They became the community volunteers. So we need to apply the same principle, which is underlying this model, to a urban setting or a semi-urban setting or even a richer locality. It applies. Basically, what it is saying is that you have to engage a community representative who acts like the bridge between the community and the system. I think that's the lesson. So these are, I think, thanks for deliberating this story. I'm sure people who, I mean, since all these proceedings will be again summarizing as a proceedings and disseminate across the world, because it's not just for this audience, whatever we are talking, it is for rest of the world as well. So we will try to bring out what are the insights that came out of this story and then try to put in the proceedings of this. Then, as I said, as a researcher, since Ashish represents the research stakeholder, right? From George Institute, because he tries to crystallize the core principles underlying a model which can be scaled up. And George Institute has been working mostly with the frontline health workers in all its dimensions, not just from a clinical perspective, but I think from all angles, from community angle and the social angle. And they have been working on the very concept, because health workers, frontline health workers, or even in the hospitals, they're also people. Their health also has to be secured, especially during a pandemic like COVID. I mean, the social stigma they faced and all those things. So, I mean, one of the concepts that we adopt when we say people-centered, we take care of people who take care of our patients. That is a true people-centeredness. That means we take care of our staff and the staff takes care of our patients. So some of these thought process, but from your field level research and those insights derived from that field level research in terms of the front level health workers, and how do we build resilience within them, not with the system, but as a community, the frontline health workers, and also their role in building the community level resilience. Ashish, over to you.
Thank you, Dr. Reddy. And I think it's important for us to begin by acknowledging the role of the frontline healthcare workers, because much of what I think I'm going to be speaking is really not something that we can take credit for. Almost everything that we'll probably speak or refer to, the resilience stories, the innovation, all comes from the periphery, the people who are at the front lines. All we're trying to do is present some of these aspects. So I just want to be careful to present it in a way where we give credit where it is due. Thank you again for having us be here. And it's lovely to hear the stories that, Raman, Kapil, and Dr. Prasad, the others have also shared. What I'm going to try and do is just make some initial comments just to reframe the questions, but also try to focus on three types of stories if we have enough time. Otherwise, I'll pause. Focusing on coping, community level coping, community level innovation, and community level leadership, and how that really contributes to resilience of the health systems. As the Resilience Collaborative, we are a community of practice. We are a global community of practice focusing on health worker resilience. And our attention is looking at generating evidence and making sure that is adopted. So it helps frontline healthcare workers' resilience, but also to stabilize quality of care during crisis. So in other words, how does a health system survive a crisis? And our entryway into the system really is the healthcare worker resilience. There might be other ways also to consider, but just for our argument's sake, just for our presentation right now, we're focusing on their input. So at this point, we have close to about 600 members globally across 29 countries. Less than a third of them are frontline healthcare workers. So we want to make sure they are contributing to research prioritization, but also making sure they're part of the entire implementation and prioritizing what needs to happen and how does resilience actually take shape. So a couple of stories I'm going to share, but I think it's also worth highlighting that since we are anyway partnering with Access Health International, your teams have partnered with us, and so have Dimagi and Reach, who are other partners in the active work of research or research mapping. So we are grateful that we can actually function as a collaborative along with the healthcare workers. And so this is close to 29 countries, different areas. And we're also hopefully going to be engaging with IDEO. But we are pushed to this because as a research organization, this is not our remit. But we realize that we cannot isolate ourselves and say, just because this is a healthcare crisis, we're going to focus on health. Everybody else focus on whatever else you're doing. That's not how it works. So we're just happy to engage with IDEO and see how frontline healthcare workers' nature as a bridge could interface with local governance, how their knowledge, how their experience could really be leveraged. So hopefully we get that project to move forward with. So our work is participatory. In other words, it's not desk research. It's not just capturing other people's research and repackaging it. We want to test what interventions happened. Why did it lead to resilience? How did it land in crisis areas and so on? So all of it is participatory. Most of the work is going to be If we're able to share, we're happy to share the links of our research. But two important points to quickly make is our shared understanding of what is a crisis and what is resilience. Crisis, as we understand, crisis, the nature of crisis, these are living organic systems. Only for convenience sake of our research that we draw boundaries around them and call them health crisis, governance crisis, supply chain crisis. These boundaries are only temporary, and it's only just to help us study things well. It makes a big mess because we can't really understand how things work on a micro level, meso level, micro level when we create these boundaries. But the good part is, it's easy for us to take some of these things back to the community and they can engage with us very, very clearly. We need situational awareness of all the different parts that we are engaging with. And that reflects on the nature of resilience. As we started to work with communities over the last 3 or 4 years, every time we spoke of resilience, it seemed like a government program, right? In different countries, people were not sure what this is. So we went back to systematic studies and we found the same level of confusion there. It's not clear what resilience means for different industries. For supply chain, it may mean something different. For combat, for armies, that means something very different. For water sanitation, all of these elements seem to be very, very different. So we found that level of disorientation to be fairly present. And so what we thought would be a good thing is to take this mess back to the community and ask them, what do you understand by resilience? And we always use metaphors to explain what it means. It means like this tree that fell, came back, my cow, or a relationship with a mother-in-law. They're focusing on live examples and metaphors. So we use that, and we're happy to share some of those elements as part of our research itself. But coming back to the stories of what really has resilience look like, we have taken some of these, maybe about 4 countries is where we've created spaces where we sit with health workers and ask them, what are your stressors? How are you coping? And what are support systems by which you can influence your own life, your meso, your community level life, and your macro life? So we've had over 150 people that we've engaged with across different states, and specifically in Maldives and Zambia. And inadvertently, what really happens is when you sit and talk with people about their resilient stories, we need to have a psychologist with us because most of these stories are very heartbreaking. People will break down because the trauma is just below the surface, and somehow they're performing at a level which allows them to finish their duties, but they're also actively caring for the community. I don't know how they do that, but they're providing care in spite of their own trauma, their troubles, and so on. So it's amazing. I think something to be really grateful for. And this is something that we've experienced. And one example I can tell you is I called the lady Sumitra. We were sitting in an immunization center, and everyone's dressed up very nicely. This lady comes up. We're asking them stories about who is your inspiration? How did you become an Asha, and how are you supporting this catchment area? This is Kampirganj in Gorakhpur area. And this lady speaks with a lisp. She's not able to speak very clearly, so she's very conscious, but she wants to explain her story. And she began with her story of her child having polio or some other form of disability that went along with it. She wanted help for the child. She couldn't find that help. Over a period of time, she found some help, but she said, if I can find help for my child, I can certainly provide that level of support for my village. So there is something that lady presented as a leadership capability or something that worked for her that she wanted others to share. There were 5 or 6 others there, and one story led to another, and almost everyone had very heartbreaking experiences in their own personal lives, but that did not limit them. Somehow they were able to see what worked for them and start to scale that. So to respond to your question about how do things scale, people see things work for themselves and start to build that. But it was hard because we had to pause our conversations many times because many issues showed up. Much of the trauma and so on started to show up. So that is one very small example of how that scaling up happened, overcoming personal trauma. The other example going to share is when we set up the India Health Accelerator Program, and then the context for that was the lockdowns during the COVID. And at that time, it wasn't very clear how are the healthcare workers going to be able to provide support, how are they going to be supporting the communities. And there was a lot of suspicion. Are the healthcare workers carrying the virus? There was fear, mistrust, disinformation, all of those things. So we wanted to find a way in which we could support them and accelerate the care pathway. So it made sense for them. They were validated in a way, but also we were pushing innovation in areas which were fairly risky. One story that that I can talk about is when we went to Guwahati. This is the Kamrup, and some of the health workers, the Anganwadi workers, ANMs, and so on, said, whenever we go to a village, people throw stones. We are very unsafe, but we have to do our job. So a normal human being would say, I'm facing a lot of adversity, resistance, opposition. I think I should be focusing on my safety and stop the work there and give a genuine reason for stopping that work. But what they said was really surprising for us in terms of their response. They said they kept going, kept getting beaten up, chased, and so on. After a while, a few group of them, they decided to come up with a campaign that they called I Love You campaign. And so all that really meant was they wanted to communicate to their blocks, a number of blocks, that they're there for caring for them, to have the villagers really trust them. I don't know how they came up with this, but this is in many, many ways process innovation. This is something that people have been able to do without a lot of support. In fact, I would say, in spite of the absence of support, they were able to come up with something like this. And so they did all that they could, but try to communicate using loudspeakers that they are safe, they want to care for them, and so on. And gradually, over months, people started to reach out to them and ask them to, allow them to come inside their villages and so on. But it took a lot of courage. I mean, this is something that you expect from a military kind of functioning, people who are committed to it, and they'll go and deal with whatever the crisis is. To expect an ASHA worker to do something like this, for us is not just surprising, it's amazing.
Yeah.
So what I'm asking, I think, Dr. Reddy, you and through you, the community itself, is to find ways in which we could still start to harness bright spots like this and to say things that are happening at an individual level, at a community level, which are really contributing to dealing with crisis. And this won't get reported because this isn't sensational in many ways. But in case we can capture ways in which we can start to look at practices on the ground in different places, and these are going to be mostly the poor or people on the peripheries, and start to look at ways in which we can pollinate these ideas in different states or blocks or countries, I feel people will be encouraged by something like this. One more step, and I think I'd probably stop after that, is we also needed to understand what's the problem, what's happening, why do we need resilience, what's going wrong. So our problem definition, theory of change, again, focusing on this element really at the tagline of resilience theory to deployable action. We needed help there. So we said, let's find out how does that entire pathway, how does a crisis emerge, how does resilience emerge, and how do they interact? It's not just the positive and negative or the infection and the medication. How does their interaction complicate matters? So we wanted to begin doing that. And so we ran a brief study really across 10 countries which were facing different expressions of the polycrisis, whether it's armed combat, climate health challenges, poor governance, migration. I mean, multiple elements so ranging from Haiti on the one side to Polynesian countries on the other. We began to ask healthcare workers really these questions. What is the theory of change? How does change really happen? And so on. So we've captured some of that in our reporting, and we're happy for us to keep working on that, because I think this is just a starting stab at how we understand some of these things work and are emerging. So at this point, I think I'm going to stop and see whether there'll be probably more dialogue over questions.
Yeah, thanks, Ashish. I think all the 4 stories, I think they're amazing stories in a different way. A lot of insights are there. I think a lot more time is required to actually digest and then dissect it so that you bring out a actionable, scalable insight which can be disseminated. So as I told in the beginning of a GLC session also that because of the time constraint, what we do is we bring out issues that could not be discussed because of the time. Then we convene a focused 90-minute sessions online by a community of practitioners and interested systems people. So it builds upon each other. I mean, so each story is telling some things. But finally, everybody will see that these are things which are doable. Right? So that you don't have to demonstrate it, actually. So we promised that. I think, unfortunately, I'm a stickler to time, but already I exceeded the time. If any, just I would like to seek any questions or comments from the audience. Yes, please. One microphone. We'll give this.
Hello. So I'm Akhilesh. I'm a writer. I write on health. So my question is to, I mean, all of the three, but especially Raman, who visited with me in Balia, and he saw the ground reality. And I'm quite concerned about the panchayat level system. Balia has more than 900 gram panchayat, and I am from that area. And unfortunately, I never saw any such health worker on the ground roaming anywhere. I mean, it may be a coincidence, but a social person like me never saw that. And Raman also was there for some few days on a very serious story and doing that health. I mean, the crisis there, the huge crisis. And he also didn't see a single health person there. So I would like to ask question to Raman that when we talk about panchayat, we talk about panchayat of those states which are quite aware, like the Kerala and the Assam and the Maharashtra and Chhattisgarh. Why not we talk about the states like Bihar and UP, where Gram Panchayat system are not that good as far as awareness is concerned, and the ground reality is, I mean, he is the witness. Please impart some light on that.
So I mean, the challenges that you are mentioning about Uttar Pradesh, yes, it is. How should I put it up? I mean, it is something like for that specific context. I should give a second. I should take some 1 minute or so to explain that this was about arsenic contamination of water. And multiple villages, lot of cases in a very severe, almost 7 deaths, and I was doing verbal autopsy of the people who passed away, talking with their families and to establish the cases actually, whether it is related to arsenic contamination or not. You are talking about that particular thing, but the limitation was that because our study was family centered, we were not really going to the health worker centered approach on that. But on the other hand, same Balia, I have another recall that we were doing as part of the literacy campaign. There was a program called Gaon Ko Jaane, Gaon Ko Badle, meaning for those who don't know Hindi, know your village and know my village and change my village. That was the thing. So when this was done, the thing is that again it goes back to what I said. There was a lot of response from panchayat and all that. Now we need to look back. This is where we were trying to talk to the health minister, I mean the CMHO office. we were trying to meet the NHM persons and all that about how can they do some changes on this, how the plan can accommodate some of these issues and look at people's challenges over this. But the thing is that unless we build these cases, the ASHA worker, for example, I generally don't call ASHA worker because the A at the acronym is talking about an activist. That's what is the expectation. Why? Again, he was talking about it. So this particular thing of their surveillance is, it is by design, I would say, because the health system, the kind of troubles and challenges that they are facing from the health system, compared to that, the community level challenges are much lesser. That's how I see the ASHA program. So the ASHA in that village herself was a sufferer. So for her to bring up the health system perspective was very difficult, very challenging, and what she could have done. And when you're suffering, on the medical also, that principle is very much there. So if you are emotionally attached to something, then you will not really come into. So that is the justification for those the Ashas not actively participating at the community level, but she was taking her family members to hospitals continuously and suffering with those. So she was not at all active because that the care responsibility of her was what you call narrowed down to her family compared to the community level. So this is a very typical kind of issue. So I would not put her, as, as someone, who was not caring, but actually she was caring more in this. Yeah. But the thing is that for arsenic or any, so that's where I told about the determinants, unless the Gram Panchayats are aware about what they can exactly do for this, how the GPDP can cover a planning for, using the untied funds, 50% of their untied funds, they can utilize for some of the things that can be locally installed rather than the national government's scheme installing some RO plants over there and there's no operations and maintenance and it is over. So that kind of a situation. So if the panchayats have given responsibility of this, things would have been different. This is what I have written in my final thing also. I think that is there. But of course, the last question, why we are not talking about Bihar and UP, I think the potential and the challenges of very recently, I was in Kanpur, was working on the ASHA program in the urban context that you were talking about. What was seen was that the Ashas never were approached, from the systems into, they are only on their own. Most of the time they are on their own. The systems once established them and not necessarily are taking care, the institutional support arrangements are missing. So still comparing to what support they are getting and what they are performing, there's no comparison because they are doing a lot more than what they are supposed to do in that condition. If I was in her position, I don't know what I would have done. That's how I see it. Yeah, thank you.
Yeah, thanks. I think a lot more interesting stories. Maybe next time we will give more time. Thanks all the panelists, Prasad online and all the three panelists here. Again, we'll continue this learning journey throughout the year and meet next year. Since this is the last session, I will hand over to Stuti. Thanks again. Thanks everyone.